for this opportunity. That is an opportunity for us as neonatologists, for our hospital, and also for our no-profit organization that is called U-Brain. And then it is really aiming to help people. At first, parents of babies to understand the different lesions that they may see speaking about. The guest is a big name, is a big person, is a big professional, I can say a big friend. No, you know that. And so it's my pleasure to share this opportunity in streaming, as we said. I hope you will forgive me before to introduce Professor Linda de Vries to show you what the efforts we're doing with our no-profit organization in the view of educating parents about the possibility of some disease. So if you manage to start the video, we produced a video, a cartoon, trying to explain, because the title of Professor de Vries is 40 Years of Neonatal Neurology. We believe that nowadays it's important as well to be very updated even in the way of communicating. So when we speak to parents about very delicate situation, very often they really can't memorize everything. And so we have produced this video trying to explain with simple words what does it mean to have an intraventricular hemorrhage if you are a premature baby. So if we can start to show you. Yeah.
Brain hemorrhage in premature babies. Information for parents. To understand how very delicate the brain of a baby born too early is, we need to understand a part of the brain called the germinal matrix, which is at work while the baby is in the mother's womb. The germinal matrix is a layer of cells in the baby's brain that is very important for brain development. It provides a rich and safe environment where new brain cells are created and begin to grow. These cells will later move to different parts of the brain, helping to form the connections that are needed for thinking, movement, and other functions. As a baby's brain matures in the womb, the germinal matrix gradually disappears as it finishes the job of creating new brain cells. However, since the germinal matrix is very fragile outside of the protection of the mother's womb, as in the case of babies born too early, the tiny blood vessels it contains can bleed easily. The very complicated medical words for this type of bleeding are germinal matrix intraventricular hemorrhage. To simplify, we'll call bleeding in the brain a hemorrhage. The earlier a baby is born, the higher the risk of a hemorrhage happening. Most babies who have bleeding in their brain are born before 32 weeks. This usually happens in the first few days after birth. It can also happen before or during birth. A hemorrhage is much less likely to happen after the first week of life, even in a premature baby, but it can still happen. How is a brain hemorrhage diagnosed? Babies who are born very early will have an ultrasound scan of the head. An ultrasound scan uses sound waves to make pictures of the body and shows the structures inside the body, in this case the baby's brain. The images can help discover bleeding. In many cases, babies with a hemorrhage in the brain do not give us clues that this has happened, so the images are needed to help discover the bleeding. What are the effects of a brain hemorrhage? A hemorrhage can be mild or severe. Mild bleeding is rather common in babies born very early. They are monitored regularly with an ultrasound to make sure the situation is stable. The baby's blood pressure and breathing will be carefully monitored as these can influence worsening of the bleeding. There is no treatment for mild bleeding, and the brain usually repairs it with time. Most of these babies do well, and some will not have any long-term problems. A baby with severe bleeding may have a buildup of extra fluid around the brain that puts pressure on it. This pressure can stop the baby's brain from working the way it should, and in some cases can damage the brain. Doctors will continue to do ultrasounds of the baby's head regularly to check for fluid building up in the brain. If it is necessary to drain the fluid to relieve the pressure, a very thin tube with a tiny valve is used. This is called a shunt. Widespread bleeding can lead to more serious and long-lasting effects. Some babies will develop cerebral palsy, which is a condition that affects movement, posture, and coordination. Some will have learning, speech, and behavioral difficulties in early childhood. These long-term effects can happen with any brain hemorrhage in newborns, but are much more likely after more serious, widespread bleeding. Sadly, some babies with very severe bleeding do not survive. Going forward after a germinal matrix hemorrhage. Not knowing what you and your baby will face as a result of a hemorrhage can be frightening and overwhelming. The Neonatal Special Care and Intensive Neonatal Care team at Gaslini Institute, together with EU Brain, provides comprehensive care, support and information to parents and families of premature babies at risk for hemorrhage and other serious brain-related conditions. Learning about brain hemorrhage is important because it helps us understand the special care that premature babies need soon after bleeding in the brain has been discovered. It is common for premature babies who have had bleeding in the brain and other serious health concerns to be in the hospital for several weeks, even up to 3 months, so that any complications can be managed by experts. During this long stay in the hospital, parents are encouraged to be with their baby as much as possible. The baby will continue to be followed by experts for the first several years of life to monitor their brain development, to provide support in facing any challenges, and to celebrate your child's progress with you.
Okay, thank you for your time. Before the speech of Professor Linda De Vries, let me asking Professor Agosti, who is the president of the Italian Society of Neonatal Medicine, to introduce together with us Linda De Vries, that she's absolutely a well-known person in our group of neonatologists. So if Massimo, are you connected?
Yes, I'm connected.
Thank
Can
you.
you hear me?
Yeah, we can, please.
Okay, thank you. Many thanks to Luca, to my friend Luca, for organizing this exciting meeting and for inviting me. It's a special honor for Italian Society of Neonatology and for me personally, especially, to introduce Professor Linda De Vries. We all know her, but I would still like to underline some aspects that are very relevant for us neonatologists, as Luca said just before. She's a distinct professor with an impressive track record of achievement and awards in neonatal neurology, particularly for her lifelong contribution to the care of the newborn brain. Professor De Vries had the remarkable foresight to recognize the importance of investigating neurological issues in newborns through a wide range of techniques. She pioneered a multidisciplinary approach, especially in neuroimaging, from cranial ultrasound, from echography to RMN, to magnetic resonance, or in neuromonitoring as well, from electroencephalography to NIRS. And then in neurobehavioral and developmental assessment of infants and children as well. She has authored numerous impactful and informative papers, including many chapters in textbooks, in major textbooks, and several books in the field. I saw that she has authored over 500 scientific papers, an H index of 89, more than 50 books, chapters, and 4 books published in multiple editions. For all these reasons, I'm truly delighted to have Linda De Vries with us today and look forward to hearing her speak. Thanks, Professor De Vries, for to be with us, and thanks, Luca.
Thank you so much, Massimo. Thanks. And now is the time to introduce Linda, please. Linda is a great friend. She's a great neonatologist, and she has teaching many of us many things. And she's still very helpful for many colleagues around, I can say, honestly, around the world. Yes, we were discussing, she doesn't like to be recognized as H-index person, but because I mean, in this room, sometimes we speak about H-index, and H-index is pretty, how to say, admirable for a neonatologist because she has got 89. So I'm saying that Professor Ravelli can't be here to say hello to all of you because he's busy in a connection with other countries. And so even if he's reading something, I'll ask Professor Magni to say something to welcome from the academic point of view. He doesn't know he had to say something. But it's just to educate Linda in the Italian way to speak.
Good afternoon. I was not waiting on this. I didn't expect. So welcome to Italy, Linda. We met each other this morning for the first time, but I know about your commitments and 40 years, I mean, experience in neurology. We will be happy to listen to your lecture. I'm pediatric endocrinologist. Unfortunately, I'm not a pediatric neurologist, but indeed I'm involved, and one of my interests is related to the neurology of the pediatric diseases in endocrine areas. So I will be happy to listen to you, and welcome to Geneva. Thank you so much. Grazie, Luca.
And now we need to welcome as well all the people in streaming, and giving you some data. They're not updated up to last time. Now we had something like 1,150 people registered. And these are the countries, the top 10 countries, and the other countries connected while you're here sitting and listening. And so this is not to embarrass, but I have to tell you the truth. I didn't ask her permission to do that because I was 100% sure she was going to say no. And so thank you so much, Linda. And please have your time to celebrate this day together with you. Thank you so much again.
Well, thank you all very, very much. Thank you, Luca, for your kind introduction. I first would like to congratulate your charity organization with your 10-year anniversary. Very impressive. I looked at the website and it looks really, really interesting. And also just seeing the video clip is showing that wonderful work that you are doing. So congratulations with that. Very nice. Then you asked me to talk about neonatal neurology, what happened in the last 40 years. And as you can see, I put underneath, it's a big task because really, where do you start to talk about the 40-year period? And I'll share data with my colleagues Dan in Utrecht and also now in Leiden. And I'll just go through the past and have also a little bit a look at the future. And then you, Luca, well, you say, I've been doing this for 40 years, but you've been doing this for 30 years. And on the left, I thought it was a Fiat, but you told me yesterday it wasn't. But anyway, a small car, and you collected me from the train station in the pouring rain. And I think the water came underneath my feet into your car. And this was when you were working in 1994 with Malcolm Levine. And then we've been together many, many times at different meetings. And one of them I remember very well. well was in 2008 when you organized a meeting together with Petra Hutby and Mary Rutherford, and we spent a very, very interesting and nice weekend in Solda in the mountains. 2019, Aquila, and 2023, we were at the Brain Club together in Cambridge. So a long-standing friendship, and also we share really the same interests in neonatal neurology. So 30 years for Luca and 40 years for me. And where did my journey start? Well, my journey started in London in the Hammersmith Hospital with a wonderful couple, Lily and Victor Dubowicz, and they were really visionaries into neonatal neurology. And if you now look at this slide and you can see, okay, neurological assessment on the left, a continuous EEG, brain auditory responses, and an ultrasound that was being done with this huge probe on the top of the baby's head. And this was the mask that we also use to resuscitate babies. And this is a baby in the scanner. But in those days, remember, this was 1983. It was really amazing that all these different techniques were already applied to the newborn brain. And Lily said, you know, you cannot look at the puzzle and solve it unless you are using an integrated approach. And I think this was really the vision for the future. And they were really the first in many of these techniques to develop them. And then Luca spent time with Malcolm after he left the Hammersmith. I spent time with Malcolm, who taught me how to use cranial ultrasound. And here you see him in his young years when he was doing one of the first cranial ultrasound scans, and they were using a linear array. And Malcolm was always a very confident person. And so he said, looking at the linear array ultrasound, look, here we are looking at an IVH, and here we are looking at post-hemorrhagic ventricular dilatation. And of course, that's true. But what was impossible to assess was the surrounding white matter. So during my talk, all the time I will put an example in the 80s on the left and in the recent years on the right. So if you look at a very similar case over here, then you see that there's also a hemorrhage. We heard this on the video, a germinal matrix hemorrhage. But if you angle the ultrasound probe backwards, then you can see that there are cysts in the white matter, and these cysts are much more important than the small hemorrhage that we see over here. And then, of course, nowadays we also look at the MRI, a term equivalent age, and then you can see that the myelination of the posterior limb of the internal capsule, which helps to predict motor outcome, is not great on the right side, the side of the cystic lesions. And you also see that some of the cysts are gone, and now we see a lot of gliosis. So the cysts that we couldn't see in the 80s, we can really see with good quality ultrasound at present. Then the low-grade IVH, the grade 1 and 2. For a long time, we told the parents, well, it doesn't really mean anything. They're small and you shouldn't be concerned about it. But here we see them on ultrasound, a small bleed, and we see them very clearly as well on the MRI. But we know that the MRI will give additional information about the white matter and about lesions that might be in the cerebellum, small cerebellar hemorrhages as well. This is a recent meta-analysis from Rees, published 3 years ago now. And here in this paper, we can see the forest plots, and we can see that the children with a grade 1 to 2 hemorrhage, they had a high risk of cerebral palsy and also an increased risk for cognitive outcome. But the study was ultrasound-based, all these papers in the meta-analysis, and most were showing missing probably the subtle white matter lesions and also the cerebellar hemorrhages. So for instance, you got a baby with a small IVH, and then you do your MRI, and then you confirm on this SWI sequence that there is blood in the ventricular system. But then you do your T1 image, and then you see there are lots of punctate lesions here. There's a small hemorrhage in the cerebellum as well. And then at term equivalent age, you see the punctate lesions still sitting there. And at 8 years, you are still seeing them here on a FLAIR sequence as well. So the outcome of this baby is a little bit borderline, is not related to the small IVH most likely, but to the lesions in the white matter, and they were really abundant in this case. So here in Geneva, they did a very nice study for really the first time comparing ultrasound and MRI. So not an ultrasound-based study, but also looking at the SWI images. And they showed that the low-grade images, IVH, was really important, as well as the punctate cerebellar hemorrhages, looking at the child's outcome at the age of 3 years. So here are the normal children, and here we see the low-grade IVH and the cerebellum and all the subscales on the Griffiths test. A little bit in contrast is a study that was recently done by the Toronto group. A large group of babies was studied, less than 32 weeks, and there were 73 babies that were studied with a low-grade IVH who had an MRI early and a term equivalent age. And then they found that if that was isolated, then the outcome was not different from the controls who didn't have a bleed, but the children who either had a large cerebellar hemorrhage or the children who had a volume, white matter injury volume of more than 40, they did significantly worse, as we can see here as well. The cerebellum for the language and the white matter volume being enlarged was associated with a lower motor outcome. So a little bit of contrast to the data from here. Well, PHVD, it's good to see the professor in neurosurgery sitting here as well. It is a very, very important topic, and both Luca and I like it very much, and have done a lot of work from here as well on this very topic. So this is a drawing from Volpe's textbook, and it shows very, very clearly that there is a lot of extracerebral space. So the ventricles might enlarge, but if the ventricles enlarge, you won't see it in the baby. There's no full fontanelle. The head circumference is not growing rapidly until after a couple of weeks, when the ventricles are larger and the cavity is really filled with the brain, and the extracerebral space is kind of filled as well. So to see this child like this, it's really far too late. We would like to treat them much earlier. And not surprisingly, in this paper from more than 10 years ago now, we saw that there was a poor correlation between the head circumference and the ultrasound findings. So what should we be doing with children with PHVD? Well, we should not wait for them to get clinical symptoms, because that is too long and the ventricles will be very dilated by then. So we should really treat them based on the ultrasound images and measuring the ventricles. And the hypothesis was that if you treat them early, they will have a better neurodevelopmental outcome. So one of our colleagues, Lara Leijzer, who is now a consultant in Calgary, a neonatologist, she spent time with Stephen Miller in Toronto, and she compared the data from 2 Dutch centers where we did the ultrasound on a very regular basis because we are doing it ourselves, and the intervention was based on the cranial ultrasound measures. And she compared the data with the babies in sick kids, where the radiologist was coming in every now and then to perform an ultrasound, and they did the intervention based on the clinical symptoms. So were there differences? Yes, absolutely. If we look on this slide and this slide, we see the data from the Netherlands, and we see that there were no differences 2-year outcome with regards to the motor outcome or the cognitive outcome, even in babies who were treated and needed a VP shunt. But if you look at the data from Toronto, you can see that they were treated late, and when they were treated late, their outcome was significantly worse. And we separated the 2 cities because the children in Toronto were a little bit less mature. But this was a retrospective study. So of course we needed to do an RCT, and that's what we did. And we thought we were going to do it in 2 years' time, and it took us 10 years to collect 126 babies. So as soon as these babies developed post-hemorrhagic ventricular dilatation following a severe IVH, we started to ask the parents whether they would be part of this study. So we either were in the low threshold group when the ventricular index, the ventricles were enlarging, but they didn't cross this so-called +4 millimeter line. But if they were crossing this line, then they were in the high threshold group. So the 2 groups were otherwise very similar. So the low threshold group, we were doing a few lumbar punctures as well as in the high threshold group. And after a few lumbar punctures, we asked the neurosurgeon to insert a reservoir. And then we punctured from the reservoir for a couple of weeks. And if it was needed still after 4 to 6 weeks, we would do a challenge, stop the punctures and see what happened. And if they then still needed the punctures, then we would approach the neurosurgeon and ask for a VP shunt when the baby was 2 kilo or above. So this is Mehmet Chismetchi. He worked with us for 6 months in Utrecht, and he is now a consultant in Toronto, an associate professor. And he looked at the data from the point of MRI. So out of these 126 babies, 88 had a term equivalent age MRI. And we looked at the Kido-Koro score to see the injury at term equivalent age. And we see that the children in the low threshold group were performing significantly better. They had less injury on the Kido-Koro score. Then in a subgroup of these children, we were also able to look at the volumes, only 47 had good enough quality to look at the volumes. And here we found that the relative volume of the ventricles was significantly smaller in the low threshold group. And the white matter and cortical gray matter was significantly preserved, larger in the low threshold group. But then, of course, it all comes to outcome. So we also looked at the relation between the size of the ventricles and outcome at the age of 2 years. And you can see that pooling all the children together, we see that the larger the ventricles, the worse the outcome on the Bailey, both cognitive as well as motor. So I think that we kind of got to the stage that we should not wait for very long. We should not kind of looking at these large ventricles, but they should be smaller when we start to intervene. And from the end of this trial, we learned that the children do have a better outcome when you correct for gestational age and severity of the hemorrhage. Then it was significant. So it's really important to plot your size of the ventricles into the graph that was published by Mohammed El Deep in 2020. And if you plot the data, then you can actually see what is going on. Here we see that the child had some lumbar punctures, and then we needed to put in a reservoir, and then it remained very, very stable up till here, where we stopped doing the punctures, but then you see a rapid increase in size, and then the neurosurgeon put in a VP shunt. So this graph really helps you to kind of guide your treatment. And you can see the baby had an IVH and also a bleed here in the temporal lobe. So if you go back to the 80s again on the left, then we see a very, very famous baby that everybody knew at the Hammersmith Hospital, David. And we had a lot of discussion about David because he had this very, very big hemorrhage here on the left. And in those days, we didn't do an MRI very, very early. But after about a year, we did do an MRI and we saw the porencephaly over here. But we also saw that he had a large cyst on the other side. So we were already very concerned about his outcome, just looking at the early ultrasound. But then David turned into a wonderful boy, and he had a very mild hemiparesis, and he ended up being in university as well. And Lily de Witch always was in touch with David over those years. And it was kind of amazing to see how much plasticity there is in the neonatal brain and how much they can compensate for these big lesions. So in the 90s, we looked at ultrasound and said, well, look where the lesion is. If the triangle is involved, then you are concerned about the motor outcome. And then also we started to do a term equivalent age MRI, and we looked at the posterior limb of the internal capsule and said, well, if there is myelination in the internal capsule, the child is not going to develop a hemiplegia. But if there is asymmetry like we see over here, then we know and we can start with intervention and physio and occupational therapy at a much earlier age. Then, of course, we're always impatient and we want to know earlier and earlier. So why wait till term equivalent age? And here we can see a diffusion weighted image. And the diffusion weighted image, you can look at the injury, the so-called pre-Valerian degeneration of the cortical spinal tract. So here within the first week, we can say, okay, the posterior limb of the internal capsule is involved. So this baby is going to get a motor issue later on in life. And if you're a little bit too late for the diffusion, which is usually there as an important finding during the first 7 to 10 days, then you can use your diffusion tensor imaging. And you should be looking at these blue lines that are your cortical spinal tracts. And they are not blue on the left side. And you can see the baby has got injury to both hemispheres, but the blue one on the right side is preserved. So we knew that the child would get again a hemiparesis, but not a quadriplegia. And we dared to continue. And then at term equivalent age, we were able to confirm this because now you see the asymmetry of the posterior limb being preserved on the right. And again, you see the asymmetry of the blue lines being better preserved on the right than on the left. And indeed, he developed a hemiparesis. And then I think we should be very cautious because we kind of talk about a periventricular hemorrhagic infarction. And there are 3 babies here who do have a PVHI, but they're very different. Here we would not be concerned about the baby's outcome. It's very small, it's very anterior, and maybe there will be some cognitive issues, but certainly not motor issues. But these children, they are different. We can see on the sagittal plane that the trigon is involved, and one of the lesions looks a bit different. This one is more globular, this one is more fan-shaped. But you see the term equivalent age, they both have an asymmetry of myelination in the posterior limb. So report the size, but also especially the site of the injury. And this is what Stephen Miller's group has done in a paper last year. A very nice paper, as always, a large group of preterm babies, less than 32 weeks, and 92 had a white matter injury or PVHI. And you can see here at the white arrow, this part is important for language and also for motor outcome. And we can see in this graph that the size of the lesion was also related to the outcome at 18 months. Let's move to the cystic white matter injury, what we used to call cystic PVL. And this was very common in the days that we both worked in the UK. I think we saw this like 8 to 10 times a year, and now we see it about once a year. So that's really major progress. There were cysts in the white matter, and it usually was visualized just after the baby was extubated, it was getting better. And then you had to go back to the parents and tell them, no, your baby has got cysts in the white matter, and we are concerned about the outcome. Now, this is one of our physiotherapists who did a PhD thesis, and she shows here that CP came down from 6% to less than 2% over this period, and this coincided with a decline in the cystic PVL, which is the main predictor and predominant for motor outcome. So this is really kind of good news. But of course, we still see it every now and then, and you can already say, well, likely we are going to see some marked diffusion abnormalities and subsequent cysts because the injury in the white matter looks very bad on ultrasound. It's inhomogeneous and very echogenic. And then again, the diffusion plays an important role because you can see here there are extensive diffusion abnormalities, and we see that the cortical spinal tracts are involved as well. And as soon as you see this so-called confluent diffusion restriction, you know the child is going to develop cystic lesions. And for those who know that I like talking about the posterior limb, you also see that on both sides now there is no myelination of the posterior limb, so bilateral cerebral palsy. Sometimes it's not so easy on ultrasound, but here again, we are concerned about the amount of echogenicity in the white matter in this part of dichorionic diamniotic twin and placental abruption. And we decided to do an early MRI to take benefit of the diffusion changes. And you can see that on the T2, of course, you see the IVH, and you see that there might be some changes in the white matter. But on the diffusion, you see again the severe confluent, very extensive diffusion restriction, also going all the way down in the cortical spinal tract, and here also in the cerebral peduncles. So cystic PVL is really very bad prognostic sign. And you can see in this forest plot, again, in the nice paper by Rees, that this has got a very high odds ratio for subsequent development of cerebral palsy. Now, Joe Volpe, the founder of neonatal neurology, he was already very, very clever and always had something new to say. And here in 2007, he said, well, if you have injury to the white matter, it's not just the white matter that is going to get a hit, because the effect of the white matter on other parts of the brain is also very important. So it will affect the central gray nuclei, it will affect the pons and also the cerebellum. And then we had the pleasure of working together with Serena Council in London. And this is our PhD student, Carina Kersbergen. And we can see here that she kind of looked at all the scans twice, the scans of London and Utrecht together. And you see that the volume of the thalami is the same at the first scan. But then at 40 weeks, you see that there's a gap. So there is no growth of the thalami in the children with cystic PVL, or hardly any. And you can even visually see that in this child. So not just the white matter is affected, but also the central gray nuclei get a hit. If we go from the large extensive cystic lesions to the more focal cysts, then we see here again inhomogeneous echogenicity, and then an early MRI showing a low signal in the white matter. So there's hemorrhagic white matter injury. There's a germinal matrix hemorrhage as well. And then 4 weeks later, we see these small cystic lesions here, very kind of posteriorly in the parietal white matter. And then we did another scan at 40 weeks. But now at 40 weeks, we no longer see the cyst, but we just see some scarring, some kind of focal lesions here, same on the MRI. And we see them here in the axial plane as well. So here again, it's really important. If you have just done the early scan and you do your term equivalent age scan, you would have missed the cyst and you would have classified this baby as having punctate white matter lesions. So your interpretation and you're looking at risk factors would be very different. Unfortunately, this baby did really well and didn't develop cerebral palsy. So we always have a discussion about inhomogeneous echogenicity and how do we deal with it? How can we predict outcome very early? Well, you can do your ultrasound every now and then, every week, and see what happens. It's transient, it will disappear, there are no cysts, and there's no ventriculomegaly. Or you can see that after a couple of weeks, fortunately rare, we see cystic evolution followed by ventriculomegaly. But if you're a little bit impatient like I am, then you can also use MRI and try to kind of see already early on what is going to happen to this child. So if you perform your ultrasound early, you can take, again, benefit from your diffusion, and you can see all these punctate lesions in the white matter. And this is really quite difficult to predict carefully with your ultrasound. And you also notice that in the same baby, when you scan the baby again at term equivalent age, all these punctate lesions are no longer apparent. There are just a few there. And that's also one of the things that Stephen Miller pointed out to us, that they are kind of less bulky and they're less visible at term equivalent age. When you look at the MRI, here a T2 and here a T1, then you see these punctate lesions more clearly on the T1 than on the T2 sequence. If you look at them, then you look at the children twice, like we did here a couple of years ago, well, a long time ago now, 112 babies. And then we found that in a third of the babies, the lesions had resolved. We could no longer see them on the second scan. But also in 20%, they were seen for the first time on the term equivalent age scan. So we always kind of arguing, you know, we should not be doing too many MRIs and it's expensive and it's time consuming as well. So when is the best time to do the MRI? Well, that's still really not very much solved. This is a nice paper from Terry Inder's group from last year. And she did the MRI twice and she looked at the MRI early and at term equivalent age. And you can see that the normal cases are coming down. The milder cases are increasing, as well as the moderate ones and the severe ones are coming down again. But in this study, it was not yet related to subsequent outcome. So of course, that's the main question, which one is more important to predict 2-year outcome? In the beginning, they looked at the Miller score for counting the punctate white matter lesions, and at term equivalent age, they looked at the effect on maturation using the Kido-Koro score. We did do a different white matter injury classification score in 2016, because as I mentioned, you can see the diffusion abnormalities, then you see the cyst after a couple of weeks, and at term equivalent age, the cyst may be gone, and then you want to look at myelination and gliosis. So to be able to score the severity of the white matter injury at all different time points, we produce this table so you can look at the scan at the time that you're scanning the baby and say, well, this is the grade of the white matter injury. And here's Stephen Miller again. He built this beautiful template of all the punctate lesions. And he said, well, where are they important? And we can see, as expected, that if they're mainly in the frontal area, then it's related to cognitive outcome. And if it's more widespread in the frontal parietal white matter, then it was related to motor outcome. And these children were seen again at the age of 18 months. But Stephen is always very kind of curious, and he always likes to think about new ideas, and he wants to keep things simple. So he came up with this paper, which is called a simple white matter injury imaging rule. And he looked at all the children early, and he drew a line across the middle of the lateral ventricles. And then he said, well, if the lesions are only posterior to this line, then the children will be doing well at 4.5 years. But if they also cross this line to the anterior part of the white matter, then the children are going to have issues, both cognitive as well as motor issues at 4.5 years. Well, I always agree with Stephen, but sometimes I disagree a little bit as well. So we looked at this again ourselves, and you see here a case with a blue line. And on the right, we see that they cross the line anteriorly. So you would expect a motor problem on the contralateral side. But if you look then at the sagittal plane, I think this is very useful as well. And you look at the side of the central sulcus, and you see whether the punctate lesions are spreading out underneath this central sulcus as well. And you can see that this happens on both sides. So the child did develop a spastic diplegia, which was a little bit more severe on the left than on the right side. Then the cerebellum, which also has played a major role here in Genova. And I think it's kind of a really part of the brain that we completely ignored. And the reason we ignored it, because we couldn't see it very clearly when we were only performing scans in the mid-80s through the anterior fontanelle. And this is a child that came back later and was not doing so well at school. And that was the reason for doing the MRI. And then we got a bit of a shock, seeing that the most part of the cerebellum, at least on the right side, was completely gone. And then going back to the ultrasound pictures, we did see, yes, there is actually something there, but we didn't spot it. But now we are looking at the mastoid window, and we can beautifully see the cerebellum there as well. And if the lesions are more than 4 millimeters in size, then we can pick them up, and they're actually larger on your initial ultrasound than you see them at term equivalent age on your T2 or your SWI sequence. And yes, if you have got beautiful ultrasound like we all have nowadays, then you can also see the large lesions through the anterior fontanelle, but you get more detailed information using your mastoid view. And at term equivalent age, you can see that this hemisphere has become a very atrophic, and there seems to be a cyst here as well. MRI early, MRI at term equivalent age. And then you think, why would you like to do an MRI at term equivalent age? Well, isn't it nice to see that the supratentorial brain looks so nice and normal? There's nice myelination. And so far, at 6 months, early days, the child is doing well on the hind. And I hope the child is still going to be doing well in a couple of years from now. A nice study from Australia from 2018, where they did 2 MRIs in the neonatal period and again at 7 years of age. And then they looked at both MRIs, and they looked at the growth of the cerebellum between the 2 scans as well. And if you look at the neonatal MRI, you see that the volume of the neonatal MRI is already related to the outcome at 7 years of age. So also if they were smaller volumes at 7 years, but also the reduced growth were associated with poorer outcome, IQ, language, and motor function in the children at the age of 7. Again, a nice study from Stevens Group, looking at 36 babies with a cerebellar hemorrhage, 14 punctate, and the others were larger, and looking at these probabilistic cerebral hemorrhage maps and seeing that the lesions were mainly at the inferior side of the cerebellum. And they found that the total volume of the cerebellar hemorrhage was independently associated with the movement ABC test at the age of 4.5 years. And the size of the cerebellar hemorrhage was also associated with visuomotor integration and externalizing behavior, but not with cognitive outcome. Well, let's move the last part of my talk to the full-term baby with neonatal encephalopathy due to presumed hypoxia ischemia. And again, back to the 80s, and in those days, it's hard to imagine, but you would go to the MRI and you would sit there next to the baby for 45 minutes, and then we could do 3 slices. So you had to kind of be lucky and get to the level where the injury was actually happening. So here we do see that there's injury to the central gray nuclei on this T1. And then in the 90s, Mary Rutherford had a landmark paper about the posterior limb and the internal capsule. And she showed that if you didn't have myelination, but an inverted signal of your posterior limb of the internal capsule, then the outcome was going to be very poor. But then over the last decades, we have been able again to use diffusion. And now you see the abnormalities so clearly on the diffusion-weighted imaging. So abnormalities in the thalami and in the basal ganglia. And then we tend to use the spectroscopy as well, look at the lactate peak, which is also very helpful. And in some centers there, you're looking at DTI and also at TBSS as shown here. From a clinical point of view, we assess the baby. We never stopped doing that. But we also were able to use the AEG, the amplitude integrated EEG, to look for seizures and look at the background pattern to predict outcome, first on paper and then digital, and also together with the near-infrared spectroscopy. And nowadays, many people also use a full EEG or a video EEG, which is even better to recognize all the seizures. And then in 1995, there was this kind of really important paper by the group in London, and both in New Zealand by Alistair Gunn, but also by the group of Ossie Reynolds in UCL. They were doing very important work looking at the spectroscopy after an insult. So they used piglets, and this is Marianne Thoresen, who was the first author and did a lot about hypothermia. And we can see here there's an insult, and some did get cooling, the ones over here, and they were doing as well as the sham animals, and the others who were warmed and did not get cooling. They went in a so-called secondary energy failure and were not doing well. So an idea that came from a gynecologist in Sweden in 1960, Westin, came back and was kind of instituted and is now really clinical practice everywhere. In the low income country, not yet, but that's a different story. So the effect of hypothermia has been shown to reduce brain injury, and Luca is also part of this paper with Mary Rutherford in 2010. And they were able to show that hypothermia reduced injury in the basal ganglia, the white matter, and also the posterior limb. And Jeannie Chong in Australia also showed the same data, and others have shown this as well. But if the injury is still there, then the effect still seems to be the same, although some people say that maybe even with injury, these children do better. However, looking at the other possible additional effects of EPO and xenon, that hasn't helped so far, but we are awaiting new trials with stem cells and melatonin, and hopefully they will add on to the effect of hypothermia. Also very interesting, by the group of Geraldine Boylan, we can see that the burden of the seizures during hypothermia has really decreased a lot. So you can see that they haven't gone completely, but the burden has really reduced enormously. So that's also very good news. Now there's the HEAL trial that looked at the effect of EPO in children with HIE. And it was very disappointing because it didn't help, and a huge data set of 451 babies. And they showed that if there was severe injury on the MRI and all the children taken together, then you would have an effect on the outcome, cognitive, motor, and language. But if the MRI abnormalities were less severe, then you didn't actually see this effect so clearly. Now, why is this the case? I think that MRI is a really wonderful predictor. Maybe one of the reasons is that in spite of using harmonization of all the MRI units, they still had differences in the quality of MRI, as you can see over here. So still the message was, in the absence of severe injury, you have to be careful when counseling parents. Now they kind of moved forward, and in a recent study, they looked at almost 400 babies, and they looked at the ADC values, and they looked at areas where the ADC value was less than 800, which would be compatible with these white areas on your WI. And they said that if you have a volume of more than 1 mil, which is less than 800 on your ADC, it's significantly related to a poor outcome. And you can see that this apparently seems to be mostly in the central gray nuclei, as you would expect. And another very interesting study that was done recently, last year in Toronto, they built a template with the MRI and performed radiomics, and they were getting a tighter relation to outcome than looking at clinical factors or lab factors. And the best outcome relation to outcome was when they combined the clinical factors as well as the radiomics, which you see a beautiful picture here of the template of the central gray nuclei. And then I always have to kind of point out the mammillary bodies nowadays, which is rather new. And we looked at it in Leiden, in Utrecht, and also the data from here. And we were able to see that babies who are having HIE, whether they cooled or not, they are very likely in about 30 to 40% to kind of involve in the injury their mammillary bodies. And it's really interesting because it can be a very isolated abnormality, sometimes combined with hippocampal injury. And we know that the mammillary bodies are part of the Papez circuit, the limbic system, and they heavily related to later memory function. So if you look at the early MRI, you see that the mammillary bodies are very small, but they're very swollen here on the T2 sequence, and you see them restricted on the diffusion. And we looked at outcome at 8 to 10 years, and we found that they were significantly related to total IQ, performance IQ, processing speed, and also to the episodic memory. So this might be a marker when you look at outcome later on. It's difficult to wait for 5 or 8 years to test memory function, but this might be helpful that these children are especially at risk of developing these issues. And then finally, stroke. Very important, also something that Luca is very keen on, the stroke in the term baby and also the preterm baby. And we see here again a child from the 80s. We still use CT scans as well at 3 months, an area of cavitation. And now again with the diffusion, we can look and predict so well what is going to happen to these children. We see the pre-Valerian degeneration, involvement of the cortical spinal tract, and at 3 months we see the large area of cavitation and no myelin because there's really no area preserved in the thalami and basal ganglia over here. We can see it on ultrasound, but it takes a little bit of time to develop this amount of echogenicity. So together with Nienke Wagenaar, PhD student, and together with Francis Cowan in London, we looked at our combined cohorts of 161 patients, and we wanted to look at all the different territories of the arterial stroke in the newborn, because we felt that we were too vague. We tell parents that a third of the babies are going to develop a hemiparesis. But as you can see, I mean, these areas are very, very different. And a cortical stroke is something very different from a main branch MCA. So we looked into this and we looked very carefully, is the middle part of the cerebral peduncle and the middle part of the plic, which is actually where the cortical spinal tracts are passing through, are these involved or not? And then we came up with this table, and I think it's a very handy table to use when you're talking to parents to predict outcome. And if you look at all the children together, then you see that indeed 30% of them developed hemiparesis. But for a child who has got a main branch MCA, it's 100%. And if you've got a posterior MCA branch, it's 21%. So I think you have to really look at all these individual sites and then talk to the parents based on this. Because you also see here that only children with a main branch or a posterior branch are the only ones who are having visual field defects. Now there are exciting things happening in Utrecht, led by Manon Benders, who's the PI in all these studies. And we can see the PASSION trial, which was a feasibility study looking at stem cells, intranasal stem cells in 10 babies. And that has been published in 2022, looking at safety and feasibility. And now in the fall, there will be a phase 2 trial to randomize children to receive these nasal stem cells or not. And the other arm is the dinosaur study, and that's a study where children, full-term babies with neonatal stroke, are getting darbepoetin twice. And this is a study done together with Calgary and Toronto. And we see that we still need 2 babies, and then this study is done. And we are very keen to look at the results of this study. And this is Nienke again, and this is Nick van der A, a postdoc in Utrecht. And then finally, a study that we are just starting to do, and Jennifer is also involved. It's a study where we are looking at preterm babies with stroke, because preterm babies can also develop stroke and they can also develop sinovenous thrombosis. And this is the PhD student, Bo van Oldenmark, and this is called the Picasso trial. And this is one of twins where we can see that the child has got bilateral strokes. And also here it's important to look at the site, because this smaller lesion seems to be more important looking at the plic over here than the larger lesion, which is more posterior. So all the centers from Europe who are part of the ultrasound consortium are involved, because this lesion is usually picked up with ultrasound. And then we want to look at the risk factors and the relation to outcome in these preterm babies. So what did I not discuss? A lot. I didn't talk at all about clinical assessment, the hind, the general movements, and they, of course, are very important as well. I hardly touched upon the advanced MRI techniques and the non-overt brain injury. And I think here it's important to realize that you're moving from prediction for a single child to a whole group-based analysis, which also is very important, of course. I didn't discuss this very important paper. It is really well worth reading, a paper by Joe Volpe, Terry Inder, and Peter Anderson, where they show in this beautiful drawing how different the preterm brain at term is compared to the term baby. And you can see, you know, there's more space around the brain, there's less infolding, larger ventricles, and a smaller cerebellum. And it's really a beautiful editorial. I didn't talk about nutrition, pain, music, sedation, and sleep, all very important. And I will just show you one slide about the socioeconomic status, which is also a very, very important topic. So again, a study from Stephen Miller's group looking at 170 survivors at 4.5 years. And I find this really very interesting and impressive. So when you look at the green line, it's the moms with the high education, the medium education, and the low education. So if you did have an IVH or white matter injury, it didn't affect your outcome if your mom had this kind of postgraduate degree. But if you see that if you're in the lowest group, then there's quite a large effect of this lesion in the outcome at the age of 4.5 years. So I think a very interesting study. And here for the HIE population, so the term babies, again, is always the mother apparently, because looking at the maternal education and not at the paternal education, there's a significant relation to outcome at the age of 2 years. So we always, I think nowadays, have to take this into account when we're doing a study on these children. I didn't talk about the clinical assessment, the hind, the general movements, and they, of course, are very important. So I think here it's important to realize that you're moving from prediction for a single child to a whole group-based analysis, which also is very important. So what will the future bring? Well, a lot. I think we are already noticing AI, and we are doing more and more whole exome sequencing. And I think every child who comes in who is not very typical of HIE, we should be doing genetic testing. And in this paper, and it's one of many papers, a third of the babies, there was a genetic abnormality identified. The kind of low threshold, I think, is everywhere for genetic investigation. We are waiting eagerly for new intervention studies like the melatonin from Nikki Robertson and the stem cells from Utrecht. I think these studies are all going to be very, very interesting indeed. And AI, we will hear about this a lot as well. Well, if you've been on a very long journey, you'll meet a lot of very nice and interesting people. And this has really been my fortune over the years. And in Utrecht, I had a group of very nice colleagues. Now in Leiden as well, this is Silke Steggerda, this is Floris Goedendaal from Utrecht, and this is Frances Cowan that I met in London, and still after more than 40 years, we're still doing studies together. But of course, the parents and the babies should be right in the middle. And I thank you very much for your kind attention at this late hour.
Think about it, because there is time and she's happy to answer a few questions. So we have time for that. Should we warming up? Why?
Yeah, thank you very much for this wonderful presentation. I have a couple of questions about the last papers you mentioned. One is the paper in New England Journal of Medicine defining neurologic consequences. And I would like to ask you, given the increasing life expectancy and survival of preterm infants, what shifts in clinical priorities and ethical frameworks do you anticipate in neonatal care?
I'm sorry.
So the question
Do you mind
is,
to repeat?
given the survival rate of preterm infants and life expectancy, what shifts in neonatal care in terms of priorities and ethical framework?
Right, what shifts? Yeah.
Well, you see, there are two things going on together. We are going down in gestational age. In the Netherlands, we still stick to 24 weeks at present, but others, like Sweden, they go down to 22 weeks and sometimes even 21 weeks. So we get younger children who are likely to have more problems, especially when they go to school, cognitive problems, behavioral problems. We also now know that seeing the children for longer and being in touch with adults, that between 20 and 30, we see a lot of mental health issues, which has also been reported by a group in Canada a couple of years ago. So I think maybe the cerebral palsy rate is coming down because we kind of lost many babies with cystic PVL, which we don't see so often anymore. But the bulk, because many more children are surviving, the bulk of children that are having problems at school, which is about 25 to 50%, is only increasing because the gestational age is lower and more of them are surviving. So it's a big thing. And one of the things in the Netherlands why they're reluctant to go down to 23 weeks is, the children are longer in the unit. So it's difficult because we don't have the staff to do it, but also because the facilities for children who have got problems at school, we call it a rucksack, that they get additional help. Is also an issue because the money is not there and it's becoming more and more difficult. So you get more children, but how do you look after them? Because it shouldn't be that if they leave the unit, then you say, okay, bye-bye, this is our job done and we are not going to be involved anymore. And now we are seeing the children in the Netherlands up till the age of 8 years. But if you talk to the adults, then they say, why did you see us for longer? You talk about ex-preterm babies, but it's not ex-preterm. Prematurity is a diagnosis for life because we are still having issues and we will have issues in the future as well.
Thank you. My second question is related to money, unfortunately. So there's a paper on JAMA Open Network about socioeconomical status. My question is, how can we adapt these advances on neonatal care to low resource setting to ensure that global equity in early brain health care, and how the educational program of parents and environment can impact?
Well, Stephen Miller has got a very nice name, I think, for this. It's called homeomics. So like, you know, the proteomics and whatever complicated, the homeomics are also very important. And there are already studies underway that they give additional funding to families. We are in a low socioeconomic scale to kind of be able for the parents to buy new stuff, toys, and more books for the children. So to really be concerned, and especially in the follow-up, to know that these are the families, they probably need additional support and they look after even more carefully. So being aware of it is already, I think, very important.
Professor Striano, as our pediatrician, as full professor of pediatrics, but he's also a great neurologist. Can I say that?
Thank you. Not sure. Thank you for this terrific talk. You showed very well that most of the neurological outcome are based on our morphology, neonatal brain MRI and ultrasounds. And this is great. It's also nice to learn that there are initial attempts, therapeutic attempts, but you highlight also the role of white matter. This impairment of white matter, I think, is related to the impairment of multiple biological signal pathways. I'm thinking about inflammatory pathways, glutamate excitation, oxidative stress. Now, which is more likely, if you have an idea, and I guess so, to be a therapeutic target? In this sense, omics, you just mentioned omics, may be helpful to further explore these potential therapeutic targets. Thank you very much again.
Well, I cannot really answer that. I completely agree with you. It's more than just drawing a line and predicting outcome, although it might be a little bit helpful. The melatonin people are kind of very keen to start using, as well as the stem cells. But I think stem cells, it's like everybody's so enthusiastic about the stem cells. We still have to wait and see what the result is going to be. Melatonin seems to be having a positive effect on the white matter, so maybe that could be helpful. But they are going to try that first in the full-term population rather than the preterm population. I think getting the infection down in preterm infants is really very important because then every time a child has got a line that gets infected and a septicemia that has been shown as well has got an effect on your white matter and also on your cognitive outcome. And the MRI, I mean, when you look at MRI, it's mostly predicting motor outcome, and predicting cognitive outcome with normal T1, T2 is more difficult. And I think you really need all the advanced MRI techniques to be able to predict cognitive outcome a little bit better. But we are still far from that.
Lino Nobili, our child neurologist, professor of child neurology.
Thank you very much. Thank you very much also for being here with us, and great talk, a lot of great studies. My question is very close to the one of Professor Striano. So you clearly show that the lesion can really predict, and you have a follow-up looking at the cognitive and motor function. But now we are in the world of connectivity, connectome, and all this stuff. So I wonder, what do you think about this post-processing analysis? Do you think they really add something on the outcome, neurological and cognitive? Can we understand much more in depth some trajectories? What is your opinion on that?
I think all these advanced MRI techniques, they are still research tools. And I think, looking here, beautiful MRIs, but there are many centers in the world and where the MRI quality is not very good. And then if you don't even have very good T1, T2, then it's really difficult to do anything else. And if you ask many people, what are you doing? Are you doing DTI? Are you doing connectivity? Most people are not doing this yet. So there are a few centers that are really excellent researchers and they're working on this. And I think it's important. And I think it's especially more helpful to understand the underlying problem. Why are we seeing the difference in connectivity? How can we deal with this? How can we work on this? What are the risk factors? But as I said before, for the individual patient, it's not going to be very helpful. And but you know, in the future with AI, well, we all think about AI as being something wonderful, but I think it will help us a lot in these difficult techniques as well.
I think your message is very strong. So why we have to spend so much time making some post-processing analysis if you can have just looking at the lesion position and I don't know.
Well, that's the beginning, but if you want to go further, you have to kind of also use other techniques which are more complicated and more time-consuming.
And so another question. I have seen that you have within the collaboration Samsa Natalo. And have you found also any correlation of your morphological data with EEG data? Are they correlated sometimes?
Yes, there have been one of the people in Utrecht, Maria-Luisa Tatarano. She has worked together also with SAMSA, and they looked at the interburst interval in relation to growth of the brain, and especially related also to the cerebellum. And there have been studies showing a correlation. Yeah.
We allow even neurosurgeons to ask questions. So we got even. I'm joking, of course.
Yeah.
Armando Cama.
I'd like to know what is your opinion or your experience concerning the prevention of post-hemorrhagic hydrocephalus using external drainage of CSF.
I think that early drainage is really very important. We've never in Utrecht used external drainage. We always asked for a reservoir and then put in the reservoir by the neurosurgeon and tapped. Now, I'm sure you're aware there's the Enliven study in the UK, where they randomized the child to a reservoir or neuroendoscopic lavage. And when it seems appealing that you kind of get all the bloody fluid out in an early stage to prevent PHVD, but it also seems to me quite intensive, taking the baby to the ER, the OR, and flushing the brain for 3 hours or so till it's clear. I think the external drainage is also an option. I think it's just what are you used to, using a reservoir or doing the external drainage. But I think the most important message is that we should start early and not wait till the baby is getting clinical symptoms.
Question. Have you, what is your experience concerning your patients who received early selective rhizotomy to treat toxicity?
So the rhizotomy, so the treatment for spasticity.
Okay. No, I have no experience with that myself. They all go to the pediatric neurology department.
Please, Sarah. Sarah Uccella, please.
Thank you, Professor, for this interesting talk. I would like to ask you a question going back to clinical practice. Beside the major brain lesions and maybe the most critical posterior punctate white matter lesions, on which risk factors you would bet for guessing a clinical outcome of very preterm infants that go to the neurodevelopmental path? So
When they have punctate lesions? Or
no, sorry.
No lesions.
Exactly, no lesion or very mild lesion, maybe no lesion in general. So which clinical factors you would... point out.
If the brain is normal.
Exactly.
Yeah. Well, then I think the socioeconomic status comes in very, very high, maternal education, but also having been exposed to the infection or surgery, or the BPD has been shown to be very important. Also in a meta-analysis from the Netherlands, they showed that the BPD was really important and for the later cognitive outcome. Yeah, and then I think, when you do not see anything on your MRI, you're probably likely to see differences in connectivity and volumetrics, and that might then be also predictive of subsequent outcome.
Thank you. Because sometimes we see exactly these babies that have no lesions, that maybe, yes, have been ventilated for a long time, but did not achieve the diagnosis of BPD, and they go very bad soon. Thank you.
Yeah, it's okay, no? Yeah, because Professor Agossi was saying, texting me that there are a lot of questions from the planet, but I don't think it's the place to answer these questions. And we just offered the air talk in a very open way, so I think it's more than enough. I thank you, everyone here. I'm not asking any question. I'm just booking you for the next 10-year talk. Is it all right? Okay, fine. Okay. So we'll see each other in a short time in the future. And I thank you so much. And Linda, thank you so much again. Where are you? For the talk, for the career, and for the person you have been to all of us. And so we want to celebrate you in this place. Thanks again. Now, you are free. Quite few of you may stay because we're going to show a few things of your brain. So everyone who is happy to stay is more than welcome, and for 10-15 minutes only. Okay, thank you so much to everyone. Allora. No, 5 minuti di pausa.
Ciao Luca, grazie.
Grazie Massimo, grazie a te.
Complimenti, davvero complimenti. Eccellente.
Non per me, grazie a tutti.
Prof, io posso staccare qua?
Sì, e dobbiamo registrare una. Ma grazie Pasquale.
Ok.
Grazie. Pure venuta. Grazie.